Welcome back to the Dental Clinical Companion, where we bring together the world's leading clinicians and experts to optimize your treatment, educate, and inspire and energize your professional goals. And now, here is your host, Dr. Richard Mounts.
We are live from Studio 1A in Neskowin, Oregon, on the beautiful Oregon coast. Welcome to this episode of the Dental Clinical Companion podcast. I'm your host, Dr. Richard Mounts. This episode of the Dental Clinical Companion is produced in partnership with Medmark, the U.S. publishers of Dental Sleep, Endodontic, Implant, and Orthodontic Practice magazines. Experienced and novice dental professionals alike turn to Medmark Media as their trusted source of information, knowledge, and education in the highly technical yet constantly evolving dental landscape. MedmarkMedia.com. My guest today obtained her BDSC dental degree at the University of Melbourne Dental School in Australia in 1976, her diploma of clinical hypnosis from the Australian Hypnosis Society, an advanced diploma at the School for F.M. Alexander Studies, and is the founder of Optimum Dental Posture. Practicing in Melbourne, Australia for over 30 years, my guest suffered frequently from neck, back, and shoulder pain. Doctors and physical therapists offered short-term symptom relief without identifying her condition as work-related. She recovered when she learned to recognize and change harmful work postures by applying biomechanical design principles. She founded Optimum Dental Posture to save her colleagues from suffering occupational chronic pain. My guest has been a presenter at Australian Dental Association congresses, continuing education courses, and group meetings. Trained in mind-body calming techniques and inner ergonomics, she trains dentists and their teams around Australia and New Zealand how to reduce occupational chronic pain and stress. Her vision is the integration of inner ergonomics and wellness training into the dental school curriculum. Dr. Aniko Ball, welcome to the podcast.
Thank you very much, Rich, for inviting me. It's a pleasure to be here talking with you.
Yeah, I am really looking forward to our conversation because for a significant number of our colleagues, the issues that we're going to talk about are, directly related to their quality of life and their quality of enjoyment of their profession. So I think this is really valuable information, and I'm excited to share what you have to offer with our listeners around the globe. How did you become interested in occupational chronic pain in the dental profession?
Well, it was my own pain journey that got me interested. Already as a dental student, I was suffering frequent chronic neck and back pain. And by the way, I will just say that if your listeners are wondering about my accent, I was born in Hungary and I came to Australia at age 14. So I did all my higher level education in Australia and have been living in Melbourne ever since. So when I graduated, I just continued to have more chronic pain, including the shoulders and arms. At one point, I lost sensation to fingers in my left hand. Luckily, I was right-handed. I had lots and lots of problems for decades as a practicing dentist, and I tried everything. I went to every doctor, specialist, physical therapist that I could think of, and they were all very helpful. However, they were only dealing with my symptoms, and whatever treatment I received helped for a little while, and then a problem recurred. And nobody looked at my work posture, what I was doing regularly. And this is the problem that I see for everyone, is that seeking whatever help we can, although they're wonderful therapies and remedies, they will not help us long term unless we are changing what we're doing on a regular basis, especially in the clinic. That will continue the problem. So that's how I became involved, and I was at a point of having to retire from dentistry because of chronic pain. I could barely move when I came across by good fortune the inner ergonomic principles of what is called the Alexander technique, which teaches how we are designed to move and hold postures in ways that our body was supposed to be doing and what we're not supposed to do, especially when we hold postures for lengthy periods as we do in dentistry. And that was a game changer. So that's how come I got very interested in how I could help my colleagues, because it helped me to get well, and applying those mechanical design principles to my work in dentistry and also to daily life, because whatever we do in the clinic, we do to some degree. Those harmful postural habits, we do some degree in our everyday life. And so when I got well, and initially I had no intention to do further training in the Alexander technique, but eventually, about 3 years after I came across it and got well, I decided that there are enough dentists saving teeth. Somebody has to save dentists, and I decided to do a part-time training course over 4 years and then translate the learning to dental industry specific application, which I'm not aware of having been done before. And then set up Optimum Dental Posture, and I am very busy saving my colleagues.
Wow. So can you elaborate a little bit on some of the common habits of dentists that precipitate such problems?
Yes, that's a very good question. So we don't learn in dental school how to get our eyes and pair of hands into the patient's mouth. How can we gain access in a way that's not harmful to the body? And that's where problems begin. And this is why I'm so keen to get the training into dental schools. So we learned that we just got to get in there and do the work. And of course, we're under a lot of stress. I don't know about American dental schools, but at Melbourne University, all the dental students were highly stressed as we had to meet standards and get things done in a certain amount of time, which only gets worse when we are out in private practice where there's time pressure. And also we have emergency patients. And there's a tendency to bend and twist to the dominant side. So, for example, right-handed dentists will tend to bend and twist to the right, which is a function and movement that the spine is not designed to do. And I will talk about that in a little while. So that's a very big habit. And also we tend to raise our shoulder, especially on non-dominant side. What I've seen is that most practitioners are holding the mouth mirror. Let's say right-handed dentist, the left hand holding the mouth mirror doesn't have a finger rest, which means that the shoulder is raised, the elbow, the arm is raised, and the muscles that move the arm and shoulder are movement muscles, which are not designed for lengthy contractions. The other problem is that I don't know, Rich, are most dentists using magnification loupes in America?
They are. I would say, 99% probably are using some form of loupes or magnification, and virtually all of the endodontists are using surgical microscopes.
Well, thank you. This is the same case in Australia, and something I discovered only about 3 years ago, which I wasn't expecting to be a major issue, is that when I started checking the magnification loupes that dentists were using who came into my programs, those whose dental practices I went out and trained the whole dental team, almost 100% were using loupes that didn't have the correct declination angle. You know what the declination angle is, the angle at which the loupes are mounted onto the glass frame. Okay. And the problem is you with me?
Yes.
Yes. So the problem is the following, and I'd better explain a little bit of biomechanical design principle before we go any further. So the spine is not designed for bending. Below the height of the ears, there are no pivot or hinge joints, even though we can twist and bend and do anything with the spine that flexibility allows us to do. And when we're dancing and in movement, that's okay because we keep coming back to neutral. So we can squash, distort, and squeeze the disc between the vertebra, which allow us to do all kinds of movements with our spine. But then when we come back to neutral, as we do in movement, the squash disc can rebound and regain their shape. However, when we hold that twisted, bent spinal posture, then we are damaging the disc, and that's cumulative trauma that accumulates, and eventually we have pain syndrome. So coming back to what is designed to bend and what isn't, and I call this Inner Ergonomics 101, what you're doing inside yourself. The head sits on top of the spine at the height of the ears. So if you think, Rich, and all the listeners, that you had an imaginary rod between your ears, and that's the height at which the head can look down and up. The occipital condyles can literally rock on top of the first vertebra, and that's the atlanto-occipital joint, just like a rocking chair, looking up and looking down. And there's only a 10-degree freedom to look down at that joint. The next joint immediately below, C1 and C2, the axis and atlas joint, enables us to look to the left and right. And that's so close together, the two joints, because these are very small, delicate vertebrae, that we can say literally at the height of the ears, we can look up and down and to the side. And then below the top joint, below the atlanto-occipital joint, all the way down, every single intervertebral joint is a gliding joint, not designed for bending and twisting when we're going to hold it. And so when it comes to magnification loops, if we don't have sufficient declination angle, we have to bend the cervical spine below the height of the ear in order to look into the patient's mouth. And what I was finding was that even dentists who had adjustable loops, which could have been adjusted to a steeper declination angle, didn't know that they should be adjusting it. And also dentists who are working with microscopes would often be in a seated posture with their head tilted backwards. That again damages spine. It causes compression and contraction of muscles that shouldn't be contracted.
Is there a way or a rule of thumb? Let's say I'm an endodontist and I use a microscope. Is there a way to know arbitrarily what the declination angle should be?
Now, this is for microscope use, or
let's say for microscope. Well, let's start with microscope use, and then if there's also a rule of thumb for using loops.
Right. So I'm just going to draw a distinction, and there's one other part of the essential biomechanical design principle that I didn't mention, is that for dentists who are not using a microscope, the only way you can safely look into a patient's mouth is to pivot forward just a little bit at your hip joints. So the hip joints are pivot joints that are designed to transport the torso across together with the head. And then you can look down from the top joint at the height of your ears, that 10 degrees, and then look into the patient's mouth safely. And what I've found, Rich, is that pivoting forward of the torso without trying to look down first into the patient's mouth, just pivoting without doing anything to the spine, is a foreign movement to every dentist that I've worked with. So I recommend just practicing this idea of sitting and pivoting forward away from the clinic in order to be able to implement it in the clinic. And then once you have got that, so you're pivoting forward just slightly at the hip joint, once you've pivoted forward a little bit, then you can look down, and only 10 degrees, which is not much, then you should have approximately 45-degree declination so that your neck is not required to bend. And unfortunately, I'm finding that just about all the fixed loops, the ones that cannot be adjusted, have got insufficient declination angle. Some of the adjustable loop can actually get that. Also, the correct working distance is very important. Some companies don't provide sufficient working distance.
Okay.
Let me know if you've got any questions. Usually I prefer to explain this by demonstrating, but I'm hoping that I'm explaining clearly enough without anyone seeing me. Is that clear so far? And then I'll move on to microscopes.
No, it is very, very clear. What is the usual optimal focal length or working distance?
Well, it varies, of course, for with practitioner torso height and various aspects, and also what I've often seen is that some dentists have the patient chair too low or too high. So, very important recommendation is that the patient chair is positioned in such a way that you can slide your knees underneath. If you can't, then you're going to be twisting in ways that is harmful to your spine. The patient should not be too high because if your hand and wrist are higher than your elbows, and you're working the movement muscles against gravity. And I've seen a number of endodontists. I suggest to dentists to send me photos of how they work if they're having problems. And in 2 seconds, I can see some of the problems. And one of the common problems for prosthodontists and endodontists is that often the patient is too high and their hands are higher than their elbows, and also not having a rest. Another critical issue is the dental stool. And before I go any further, I just want to clarify an expression that I use. And you may have seen in some of my articles that I talk about inner and outer ergonomics. There's been massive amount of money spent on ergonomic research and development in dentistry. What occurred to me at the time when I started training in all this is that everything that we have called dental ergonomic development and research has been about the equipment, the surgery setup, instruments, which are very important. However, almost no one that I know of has been looking at what dentists are doing inside themselves. So I came up with this distinction of outer ergonomics, which is very important, and it's everything that's not you. And then inner ergonomics is your efficiency in posture and movement, the way you organize yourself. Is that clear enough?
That is perfectly clear.
Right. So what is very important is to sit on a good dental stool. And I've been looking at dental stools and I'll come back to your original question about working with microscopes. I've been looking at dental stools for the last 5 years at least, and I'm finding that most dental stools are not well designed. What I recommend highly, based on inner ergonomic and biomechanical design principles, is that the seat itself should be firm. If it's soft, then often dentists use something that's flush. It means that you're rolling off your seat bones. We need to be sitting on the seat bones. So you're welcome to do this, Rich, and all the listeners. Reach underneath and feel the pointy bits of your pelvis. That's called the ischial tuberosity or seat bones. And we need to be sitting on that.
Okay.
When we sit on can you feel that?
Yes.
Right. Now what happens is that when we sit on a soft chair, stool, couch, we tend to roll off and sit on back of behind the sit bone, which then reverses the lumbar curve. Same with car seats. Most car seats are backward sloping, so that immediately does damage. In order to sit well and utilize our postural muscles. So there are muscles that are designed for lengthy, slow contraction, and these are our postural muscles. And then there are muscles that are movement muscles, which are fast twitch, designed for a movement, and then they need to switch off because they get fatigued. We also have cardiac muscles, but I won't go into that. And so what happens is that when we're not sitting well, when we are rolling off our sit bones, leaning back, and most couches, chairs, and dental stools have got backward leaning back support, we come off the sit bones and we're undoing our lumbar curve. Also, it is best to have a dental stool that's slightly sloping forward, even just 5, maximum 10 degrees, no more, is really helpful, because the new ergonomic guidelines are that the hip joint should be a little bit higher than your knees. So a drop of water on your thigh should be rolling down towards your knees. Very important for dentists, especially tall dentists, to sit on a stool that will go high enough. And for dentists who are petite, they need to go low enough. And I often see that there are limits. So when you're buying a dental stool, if you can, make sure that it is the proper height for you. And if you can have a slight forward adjustment of the seat, only a slight one, you're then more able to do that pivot forward. When you are using a microscope, you don't need to pivot forward. A microscope will allow you to look ahead and then see in patient's mouth. So it's a brilliant way to sit well. However, it's still important that you're sitting on a firm stool. Here it's crucial that you have a backrest that will support you in the upright. For dentists who don't have a microscope and need to pivot forward slightly at the hip joint, of course, the backrest won't be used, only if you're talking to your patient. And even then, you do not want to have a backward-leaning backrest. For you, Rich, as an endodontist, it is very important that you're sitting well, not pulling yourself up. So what happens is when people hear that I'm the founder of Optimum Dental Posture, they suddenly pull up if they're standing or sitting upright, thinking that is good posture. That is actually a forced good posture. That means that people are utilizing movement muscles, the superficial muscles of the back, to pull up, which is unsustainable. By sitting well on a good seat and just thinking up inside yourself, this is called directional thinking. So, for example, thinking that your sit bones are going down into the seat without doing anything, and thinking that your spine is holding you up without pulling up. You're activating your postural muscles and deactivating movement muscles that shouldn't be active. Of course, there's a lot more to it, and I teach this in lengthy training. But that's what you want to be activating. So for you, a good chair is even more important, and you want to have your feet flat on the ground. Now, what's really important with microscopes is that you don't have your chin up. The head weighs about 5 kilos. I would say that to get into dentistry and practice as a dentist, you have to have a lot of gray matter. So you're probably in the 5.5 kilo range at least, all that extra gray matter. And the head sits on top of the spine at the height of the ears, with the base of support being slightly behind the center of mass of the head. What that means is that gravity wants to nod your head slightly forward at any given time. And there are deep postural muscles that on the back of the neck, which will stop that head wanting to roll forward. You know, when somebody's sitting up and falls asleep and the head just nods forward. Well, when we are awake, the postural muscles get that tension and register it and then activate the whole postural system to support you against gravity. So what that means is that the ideal head-neck relationship or head-spine relationship is with the head slightly wanting to nod forward. So coming back to an imaginary rod between the ears, and then the head wanting to just slightly nod forward. If you imagine a little teardrop wanting to roll down the nose and just gently nodding it forward, that's the ideal relationship of the head neck. So when you're looking into your microscope, it's very important that that's how you look in, with your nose and chin just slightly tipped downwards. And I've seen many endodontists sending me photos of the chin up, and that's how, and the head is rotated back, which then compresses the spine and contracts the movement muscles of the neck and back, and takes the whole anti-gravity support, the postural muscles, out of gear.
How different is the posture for a general dentist using loupes? Or are these principles you're describing with the nose down, 5 to 10 degrees, and these other movements, are they essentially the same recommendations for someone using loupes as using a microscope?
Exactly the same. It's just that if you're using a microscope, you can actually sit upright, but don't pull up because you can't hold it. And I've seen a lot of dentists sitting slumped or leaning backward and chin up using a microscope. So the same recommendations without a microscope, except you need to pivot forward at the hip joint and then look down.
Got it.
So
okay.
Exactly the same. And of course, there's a lot more to this, Rich, and I'm hoping that I'm not making it too complicated for you and listeners, because there's a lot more to the directional thinking. But, well, is that clear enough so far?
Very clear. Remarkably clear, especially for only having words and not being able to draw pictures. Can you give us an idea of the scope of the problem of chronic occupational pain in dentistry?
Rich, it's horrific. It makes me very sad. I used to think that I was the only one or one of few. And what I've now seen is that in worldwide, this was I looked at studies that were released a few years back now, and I believe that things have only gotten worse. And at that time, 86% of dentists around the world were experiencing chronic pain, 25% severe pain, 96% of dental hygienists. However, what I need to tell you, which most dental professionals don't know, is that we have a massive problem among young dentists. When I started training my colleagues, I expected the more mature generation to flock to my courses. And what I'm finding is that most of the dentists who are coming for help and training with me are barely out of dental school and in severe pain. In fact, 100% of them are in pain. I have presented at dental congresses for the last few years in Australia, where I might have 200 or more dentists in the audience. And I usually ask, hands up very early on in my presentation, hands up if you've been experiencing pain, discomfort, tingling, numbness, various symptoms. And I go through all the pain locations like neck, shoulder, wrist, hip. And I find that every hand goes up, and I usually ask, is there anyone who didn't put a hand up? And usually there isn't a person who doesn't put their hand up. Now, the reason why I think we have a greater problem among young dentists, and I don't believe any research has been done to show this, so this is my personal opinion and finding, is that first of all, young dentists have been using loupes from the time they were in dental school. And given that I'm finding almost 100% of loupe users have got loupes that are either non-fixed and can't be adjusted, and they don't have sufficient declination angle, or adjustable loupes are not adjusted properly, and they've been doing that from day one. They have a problem due to that. The other is that we are looking at a generation that has grown up using mobile phones, and I'd like to mention this to your listeners. we have a major problem. As I explained before, the spine is not designed for bending below the height of the ears. And what most people do, and especially young people, is they take their head down to the phone, towards their lap, which is damaging to the spine, and then they are texting and looking at the phone for a lengthy period. And what I like to point out to everyone I talk to when I get the opportunity is that using biochemical design principles, the smart way to look at a mobile phone or any device, if you're moving it, is to use a wonderful hinge joint called the elbow. So bring the phone to you, don't take your head down to the phone. And this is a major problem.
Very interesting. That's fascinating. As you were describing having symptoms and pain and everyone raising their hand, I will tell you my story very briefly. To my knowledge, I don't have any chronic problems, but I'll tell you two things. One is that my left shoulder ultimately locked up, and I couldn't put my arm around my back on my left side. And I think it was related to what you were describing as holding the mirror up too high and not having a fulcrum. And I created ultimately an impingement in my left shoulder. So what you said in that regard was really valuable. And ultimately I had surgery to remove that impingement and allow me to be able to bring my arm back, and put it fully behind my back. The other thing that's happened is that for unknown reasons, out of nowhere, I've been in dentistry, I got out in 85. I've had 2 or 3 episodes where out of nowhere, I will just have this amazing electric shock pain right across my lower back. And I didn't do anything. I didn't stand up. I didn't sit down. I didn't move. And it's just been like, ow, if that were to continue, I'd go out of here in a wheelchair, because I couldn't stand up. It'll last for 5 to 10 seconds and then it goes away. And so you're really speaking, we would say you're preaching to the choir, because I really understand the importance of the work you're doing and some of these bad habits that I'm sure that I and many other clinicians didn't know we have that have caused us this pain. So I think you're really spot on in terms of the important work that you're doing.
Well, thank you, and I'm sorry to hear that you have had some problems, and I've rarely met a dentist who didn't have problems, and there are some people who work part-time and move a lot, and they're just very fortunate, but for the most part, dentists are in pain. So coming back, and thank you for sharing that story, so I'd like to perhaps clarify a little bit, and that I myself had chronic pain that was just burning pain in my left shoulder, and of course I had my shoulder up, elbow up, and didn't have a fulcrum for my left hand holding the mirror, and this is a universal issue with all dental practitioners. What I highly recommend is, just like we have learned to have a fulcrum for our dominant hand, and usually right hand for right-handed people, we need to do the same for our left hand holding the mirror, not because we will do damage to our patient like we could with our other hand holding sharp instruments or a drill, but because we're causing ourselves harm. So the average arm weighs about 4 kilos. When we hold the mirror, and most dentists have got a kind of a hovering way of holding the mirror in the air, we're asking our movement muscles of the left shoulder and arm, which are also connected to the back, to be holding up at least 4 kilo weight against gravity for a long period per appointment. And that always leads to chronic pain, fatigue of the muscles. It's like driving a car in the wrong gear. I often use the car metaphor. You know that when you're driving uphill, even an automatic car will select the low gear. In high speed, it'll select the high gear. We're in the wrong gear when we do that. So the way to overcome that problem is to get into the habit of finding a finger rest somewhere in the mouth not against the patient's cheek, because we're then kind of holding the hand and bracing the arm, but find a finger rest somewhere in the mouth, and then use the directional thinking that I mentioned, where you're actually thinking but not doing anything. It's just in thought, that you're releasing the whole weight of your arm from the shoulder all the way down to the finger rest in a vector fashion. And that will usually help to switch off the muscles that have been active, because the arm doesn't need to do anything other than connect your hand holding the mirror to the rest of your body. And it's really important not to hold up the elbow, because I've seen people starting to practice the habit of having a finger rest and yet hold up the elbow. So my instructions are, let gravity have its way with your elbow. Your arm is not a fall off. Now, this takes us to the problem of habit. You see, it's one thing to know that you should have a finger rest. However, if you haven't been having a finger rest, and it's the same if you've been twisting off to the right, if you've been leaning back off your sit bones, whatever it is you have been doing, knowing what to do different isn't going to help, because we literally have a software in the brain. It's a neuromuscular firing pattern for movement that we have. Once we've done something at least a couple of times, we just have this software. And now we need to rewrite the software and do it different. So as soon as you think of, yes, I'm going to look in the mouth, the left hand will automatically go up, and whatever other work habits you've had will just go into automatic firing. And same with wanting to look at the mobile phone. Even though now you know that you shouldn't be taking your head down to the phone, if that's what you've always done, you will automatically do what you've always done, because that's the habit. There's an automatic firing. Even though the decision to do whatever it is you do, look at the phone, look into patient's mouth, is voluntary, the way you're going to do it is involuntary. So the big challenge, of course, is habit change. And what I recommend to dentists is to ask your dental assistant to remind you. Just say, I've got this habit where I tend to not use a finger rest, or I go off to the side, or whatever it is, or raise my shoulder, because you won't even feel that you're doing it, because it feels so familiar and comfortable, even though it's causing you pain. And so say to your dental nurse, every time you see me not having a finger rest, please wave to me, obviously not in the middle of the most complex procedure, but as much as possible, you want to be reminded in the lunchroom, staff room, in the break at work. If you see me take my head down to my mobile phone, please tell me not to do it, because I need to break that habit. And the more you break it, the more you will develop a new optimal default.
That's very important coaching. I appreciate your sharing that. Can you describe your training entity, Optimum Dental Posture? What types of courses and workshops do you provide?
What I've been doing so far is organizing workshops. I run a 2-day ergonomics and wellness training program, a workshop, and I run these in various states in Australia in dental showrooms, so that there is a training component in a seminar room where I teach the ABC, the basic inner ergonomic principles, and then we go across to the dental showroom with dental equipment and mannequin next door, and then we put it into practice, and I have assistant trainers, and I do that in Australia, and also I've done that in New Zealand. I organize programs, and I'm also invited by dental associations to run often a slightly shorter version of the program. But the 2-day is my premier program. And if we have time, please ask me about extraction, because I actually teach how to do extractions without straining your arm and shoulder, and I think I can give some ideas. I also go out to dental practices at the invitation of the practice, and I train the whole dental team, where I run a shorter training program. I find that non-clinicians I can hold their attention for about half a day. And so I teach the basics, and then I take additional Optimum Dental Posture trainers, and we train every member of the team in their workstation. And of course, I work with the clinicians, and I check loops. And that's the main way I've been teaching. Now I'm forced to go online because in Australia, as in every other part of the world, we have gone into restrictions and social distancing. And until now, my preference has been to teach in person, although I've been asked for a long time to teach overseas dentists online. I'm not offering programs yet, but I will be. I'm working on this and translating it into online
curriculum.
Effective way of teaching online.
Yeah.
And what I have just found out yesterday, talking to my insurer, is that I can teach in person or online anywhere in the world except for the United States and Canada due to very different liability and litigation conditions.
Yeah, that's really unfortunate. Aniko, what I'm going to do is I'm going to split our podcast into two parts, and I'm going to have you go ahead, if you would, and describe your extraction technique, and then we'll round out part one, and then we'll stay together and we'll record part two, just to keep this podcast from running too long, and it just would make it easier to split it for our listeners. But to round out part one, can you describe, you mentioned a special extraction technique. Can you walk our listeners through that?
I would be happy to, because this is a work lifesaver, really. I have had a number of dentists who have come into my training programs or contacted me and asking for help, who damaged their shoulder and arm after a difficult extraction. And this is a common problem that I see. So what happens typically, whether dentists are sitting or standing, is that all the work is being done by the arm and hand. And of course, we need to use our arm and hand. What I teach is that the dentist thinks of all of me. The all of me principle means that I'm extracting with my whole body. So to explain this more clearly, if I am not thinking about all of me, there's a tendency to brace and slightly stiffen, which you won't feel, the rest of the body, and then just work the shoulder and arm. If I'm thinking all of me, just that thought alone activates a whole lot of additional switches in the nervous system, and suddenly there's a whole body connection to the arm and the extraction forceps, or the elevators or luxators. I think these days they're called luxators. And so suddenly it's like you have a 10-cylinder car, and instead of running on one cylinder, you're now running on all 10 cylinders. So what I teach is to hold the, let's say, forceps in your hand. And initially we're just wanting to go up, if it's an upper tooth, or down on our lower tooth. We're not trying to extract, we just want to go further and further up along the tooth root. And what I teach is, whether you're sitting or standing, just do this slight pivoting movement at the hip joint. That's our power base. That's if you look at martial artists, the way they stand, for example, and they do it all from the hips, that's where we can express a lot of power and force. And so I get dentists to, either sitting or standing, just do that very slight movement in their hip, or even just think they're doing it, and then allow the force of that from their hips to go through to their arm and to the wrist, and see what happens. And it's amazing when dentists experience, and I get them to contrast what they normally do, which is just work the arm and shoulder, as against not doing much with the arm and shoulder other than just hold the instrument and allow the power to go through. And some of them have nearly extracted a tooth on my mannequin because they weren't expecting so much force to go through. It's quite amazing.
Wow.
Is that making sense as I describe it?
It's funny. It really does. I get it. I completely get it. And as you were using your description, I was thinking about the transference. This is kind of woo-woo, a little bit woo-woo from an endodontic perspective, but that about transferring the all of me into the root canal file as you're in the tooth. And it's not a tactile motion just with your fingers, but using, the same kind of pivot and intentionality that you just described. That has endodontic applications in my mind in terms of the thought process and bringing your whole body into how you're going to use that file within the root canal space. So yes, that makes perfect sense.
Absolutely, and I love the application because it applies to everything, whether it's scaling or whatever it is you're doing. And in fact, something for you and listeners to even experiment with is that if you pick up let's say, any object near you, let's say a cup of coffee or a glass of water, if you're thinking that you're just doing it with your arm, and your arm is and thinking of the rest of your body, it's a very different quality movement to when you're thinking all of me.
Yeah, very interesting. Well, Aniko Ball,
neuromuscular integration.
This has been a fascinating part one of our conversation. We're going to break here and come back and record part two momentarily. But I really appreciate your coming on the podcast and sharing your expertise in your important work. And we'll speak to you again very soon.
Thank you. It's been my pleasure.
Thank you. This episode of the Dental Clinical Companion is produced in partnership with Medmark, the U.S. publishers of Dental Sleep, Endodontic, Implant, and Orthodontic Practice magazines. Experienced and novice dental professionals alike turn to Medmark Media as their trusted source of information, knowledge, and education in the highly technical yet constantly evolving dental landscape. MedmarkMedia.com. Engineering and creative support from Christopher Bima, PanopticArtifacts.com. We look forward to having you join our next podcast. Thanks for listening.
Please remember to subscribe, rate, and review us on iTunes. Join us on Facebook, Twitter, Instagram, Pinterest, and LinkedIn for additional information and resources. To reach Dr. Mounts or to recommend guests or topics you would like featured, please email drmounts@dentalclinicalcompanion.com. Mounts Endo, LLC, Dr. Richard Mounts, and the Dental Clinical Companion podcast have no liability for any clinical, management, financial decisions, or other actions you take based on the information provided in this program. Please see the show notes for our complete liability release statement. See you next episode, The Dental Clinical Companion, bringing together the world's leading clinicians and experts to optimize your treatment, educate, and inspire and energize your professional goals.